Hello, my name is Ronit Elk, and I'm at the University of Alabama, Birmingham. And I have the opportunity to talk to you today about a topic that's near and dear to my heart, and I hope will be something that you're interested in too. I apologize for having my hair in a scarf. I had a little head procedure, so it was either this or a baseball cap, so just ignore it, don't worry about it. I am going to share my screen, and then we'll be beginning our talk. So what I'd like to talk to you today is about culture and how important culture is in every aspect of palliative care and end-of-life care, and especially when caring for people from other cultures or who have different ideas and different thoughts and different perspectives about end-of-life care. So I'd like to focus on our African-American patients and their families. So what I'd like to do today is to talk to you a little bit about culture, and then the impact of culture on seriously ill patients and their families, and then give you a tiny bit about some things about African-American patients that you may or may not know, and then talk to you about, well, how do we develop palliative care programs that are based on our patients' culture and lived experience? And then often, since many of the people who attend my talks are clinicians, many times I want to know, so what is it that I can do? What do you want me to do? I'm not a researcher. I'm not an educator. Tell me what I can do. And so I have some suggestions for you too. So if you look at this diagram of culture, I'm sure you all know what culture is and what culture you belong to. You might belong to more than one culture, but think about how you know about your culture so many things. But about other people's culture or a culture that you don't belong to specifically, think about what you know about it. You might know about their food, you know about their flags, maybe not. You may know about their festivals, holidays. I always think about, Greek festivals. I love it. I love their music. I love their art. I love the food. I love everything about it. I love the language, even though I don't speak it. But look what percentage of aspects of a culture that we don't know unless we're in that culture or unless we've studied it. So things that are so pertinent to palliative care, look at the first one, communication styles. What are the facial expressions that are allowed and not or considered rude? Is eye contact considered very normative in American society? It is not in many other cultures. If somebody's an elder, you look down. What are the different ways of communicating? If there's certain leaders around, or if there's a man and a woman around, all kinds of things. And then this whole way of showing emotions. Is it okay for us to do share feelings? Like I come from Israel, and in Israel, it's a very Middle Eastern kind of country where feelings are very openly expressed. It's very different in some of the other cultures, even in the United States. For example, when I came to the rural South, and I realized, there's a lot of politeness, and you don't always say the things openly. You have to sort of say it in a polite way that people have to understand. Then there's attitudes about, elders. What is your respect towards elders? What is your attitudes towards death? And then what are your approaches? Even things like problem solving. Problem solving comes very much, and decision making comes very much into end-of-life care. So let's start with the assumption that people who are not exactly from our same culture, we really don't know a lot. We really don't know 90%, which is huge. But when we are ill, think about yourself when you're sick, or any loved one. When you're ill, you perceive illness or suffering or dying through your own cultural lens. Think about patients you've had, how they've seen it this way and that way. It is normative. Every person will perceive their illness, suffering, and dying through their own cultural lens. So let's look at how it impacts palliative care or end-of-life care. the preferences for care very much vary. For example, the type of intervention you want and how much knowledge you want to know about your prognosis. It is not true that you should tell everybody, every patient what their prognosis is, otherwise you're being rude. Not at all. It might be very different in some other cultures. And to what extent is the family involved in decision making? Very much in the States, we talk to the patient directly, but what about in some cultures, it might be the whole family's involved, or even the family and a religious elder. And then outcomes of care might differ completely, like to what extent I'm prepared to go through all kinds of treatments, and why it matters to me may vary tremendously from somebody from another culture or from your culture. And then how soon I'm going to die, where I want to die, all that varies by culture. Also, the way we communicate. In some cultures, do you know that it's taboo? It's taboo to talk about death. There might be some discordant understanding between the family and the clinician, which happens unfortunately too often. And then talking about a time until the expected death is really not appropriate. Like, I think that in my estimation, if she lives longer than a week, that'll be a long time. Or in my estimation, she'll be passing very soon. Meaning in a day or so. That's not appropriate in some cultures, unless of course you're asked. That's different. And by the way, I didn't mention, but at the bottom you'll see that there's an article that explains everything in much more depth. I'm just obviously summarizing it. The meaning of illness and the meaning of pain may have a particular meaning that's different to what you think pain and suffering is. It may, some people in some cultures may think of it as a punishment for a past sin. And finally, in the decision-making process, so there's several aspects here. It depends whether the individual is the person that we're talking to, or the society is much more of a communal society. So in Africa, primarily, I'm generalizing, of course, there's a concept of Ubuntu. Ubuntu, yes, I did live most of my life in Africa. Not that I speak that many African languages, which I should, but Ubuntu means the people. So if you ask somebody, how are you? You may get a response, the people they are suffering, or the people they are hungry. And you think, wait, I just asked about her and she's talking about the people, because the concept isn't of I and me. I and me, I'm part of a whole group. And this photograph is so superbly demonstrates that. Now, in the United States, the culture is often given to the physician. The physician is the ultimate authority, whereas in other cultures, including in African-American, not all, but many African-Americans, God is the ultimate authority. So if God is the ultimate authority, you as a physician, you're not the final authority. You are the one who can know, who has the knowledge, but you cannot say when I'm going to live and when I'm going to die. It's in God's hands. And then how I want end of life, what I want you to know about my end of life, either in writing. In the US, we have a very big focus on advanced directives, but it might be verbal communication, oral communication. I've told my daughter what I want. I've told my son what I want, and that's what's preferred in other cultures. But here's the problem. The end-of-life care values in the United States are historically rooted in values that represent the cultural and religious values of the white middle class, which is fine if you're white middle class Christian, and it does not necessarily, and certainly does not apply to many other cultural groups or many other ethnic groups. And what happens is, if there's a lack of sensitivity or a lack of respect for cultural differences, not only may it significantly compromise care for minority patients, it does. And I'll give you some examples in a while. So here we are, we think we're doing the right thing, and yet we didn't realize that we needed to understand the culture in order to provide appropriate care. And Dr. Perrier Coyle has written a paper in 2016 actually labeling the fact that if we don't have culturally competent end-of-life care, it is a significant public health crisis in the United States. It's hard for people to sort of grasp that, and I've even had reviewers on Grant say, well, that's not a public health crisis. Well, that's because you are not from another culture, and you don't recognize how other people from other cultures are being their cultural values not respected. And so how on earth are we going to do this? How do we provide a culturally based program, cultural palliative care program? We do this by understanding and respecting the cultural values as well as the lived experience. If you're talking about African Americans, you cannot not talk about the lived experiences of systemic racism. So to give you in a nutshell some of the aspects of our African American patients, first I want to acknowledge, obviously I'm not African American. However, I have partnered with a lot of African American communities, and I have committed to learning as much as I can and becoming a student of African American history. And the history of slavery and racism remains in our DNA. It remains in our DNA whether there's slavery now or not. And really think about every person that you know who is African American, whether it's a student or a patient or a colleague. Racism affects the daily life of the community. Every single day, something is happening that is racist. You may feel you're not racist. I understand. I'm not accusing anybody. I'm saying that that is the reality of the life of an African American in these United States. I want to move to something slightly different, and that's the importance of faith and church in the African American community. So the Pew Center does studies around the country, and by many measures, African Americans are more religious than whites and Latinos. So for example, 83% of African Americans believe in God with absolute certainty compared to 61% of white. 75% say religion is very important compared to 49% of white people. And they pray daily, 73% compared to 52%, and attend services at least once a week, almost half compared to a third of white community members. These are people in the community. And so for those African Americans who believe so strongly in God, religion and church is fundamental to all being, to all knowledge, not only about religion and spirituality, but everything in life, everything that's happening, everything that will happen, everything that did happen, and the whole vision of life. And the pastor's role is key. And one of the biggest mistakes we make in this country in our end-of-life care is not including sufficiently the African-American pastors with our programs that include African-American patients. It's a huge error. And the other thing is that God is in charge. God decides when I'm going to die if I'm African American. Not only, there are other cultures exactly the same, but it's God that will determine. Now, here's the other thing that you really need to know. The belief in hope and miracles is very prevalent. How else do you survive slavery without hope? How else do you survive the horrific systemic racism that we have subjected our African American constituents in this country to without having a belief in miracles? It's extremely prevalent, and think about how that impacts, I put hospice care, but think about how that impacts end-of-life care decision-making, and what, when patients are very, very ill, so often African-American patients believe in a hope and a miracle, and yet the physicians and the other healthcare providers know the physiological, what's going on in the body, and so they're encouraging them to turn off or stop what's called aggressive measures. But in actual fact, what I believe in is a hope and a miracle. And so that's what I'm going to continue to put my faith in. That's a whole complicated area. We've recently written a paper on so-called aggressive care. I certainly hope it will be published soon so that we can have more discussion about it. Similar to in African countries, the focus is on family and community, not just the individual. So for many generations, African Americans, we take care of our own. There was no one else to take care of them. And in many situations, that's still the case. And so we take care of our own is how it is done. And who would have trust in a healthcare system? Tell me who would have a trust in a healthcare system when there has been medical experimentation on Black Africans, not just Tuskegee. Please don't think it's just Tuskegee. It is not. Harriet Washington, Dr. Washington is going to be speaking very soon in giving a big lecture on this, what she calls medical apartheid, but basically the dark history of medical experimentations on Black Americans from colonial times to the present. So you could say, oh no, now we have IRBs, everything is fine. No. Not at all, because we have disparities in the care of African Americans at end of life. I'm just going to give you a few examples, although I'd love to give you hundreds. Pain management. It's not assessed as well as in white patients, and it's not managed as well for African American patients as in white patients. So there's higher pain and complications. Imagine if it was you. Imagine if it was your spouse. Imagine if it was your mother or your father, actually suffering more pain simply because some clinician has made some sort of a bias, and therefore the person suffering is the African American patient. What about at end of life? Okay, let's talk about end of life. The goals of care. Oh, this we know about goals of care. We want to do what the patient wants, but it's less often discussed by physicians. It's less often recorded by physicians in the chart. And even when African Americans have the goals of care written in the chart, it's often not followed or respected. Now, I'm not saying that these are palliative care physicians, but these are physicians who are taking care of patients in the hospital. And the result, who suffers? The patient and the family. Now, what's happened in when the COVID epidemic happened, it didn't happen randomly or passively that the health inequities occurred. It didn't happen coincidentally. And I'm talking about before we had the vaccinations. I'm not talking about now, I'm talking about before. These were actively produced through an anti-Black systemic racism. So this paper was one of the first to talk about systemic racism and the concept of syndemics, which is a collusion of epidemics. I'm ashamed to say I wasn't aware of this term of collision of epidemics, syndemics. So if you have systemic racism epidemic for 400 years, then COVID comes along, that's what happens. And this is a superb paper. I haven't updated. It has been published. It's not in press. So what's happened in our country is that there's been an awakening, not only in the US, but also in the US, about how systemic racism is a public health crisis. And the impact on the Black community is horrific. This is about COVID. But what about systemic racism generally? Look at the net worth is 10 times less. Housing, we have 40% more homeless people who are African Americans. 2 times more African Americans than white are likely to be hungry. Mass incarceration, they're incarcerated at 5 times the level. And really, you don't need me to tell you about how it impacts the health of a human being to be at such situations. And if you could say, Why is there housing insecurity? Why is there wealth insecurity? Why is there education insecurity? Why is there mass incarceration? It's all to do with various policies, and that would require us to have a whole different, maybe 3-4 day training. But for right now, the reality is that the patients that you are seeing who are African-American, not only your patients, it could be your African-American colleagues, have faced significantly higher barriers than you could even imagine, and the effect on the body is horrific. So I know people get upset with me and they say, so what do you want me to do? Well, we can each take responsibility for addressing and confronting, as well as dismantling, both personal and systemic racism. And we can certainly work on disparities in healthcare. We should not accept any disparities. So for those who really want to know what to do, so the first step is, this is a paper that I wrote, let's see, 2016. Nobody paid any attention to it. Nobody, well, that isn't true. A few people cared about it, but they're the people who've cared about it all along. But following the murders and COVID deaths, now people are sort of recognizing, oh no, this is horrific, what our African-American patients are experiencing. And so if you want a first step, your first step is to recognize it and acknowledge it, and let your patients know that even if you're the most least racist person in the world, recognize that you know what they have been through and are still going through. Just say that. What else can we do? Well, we can design palliative care programs that are culturally concordant. When I say we, I mean people like me who are researchers. And then we can design training programs. Researchers partner with educators. And then we can design solutions to like if you see a persistent problem over and over, as a clinician, partner with researchers. Let us try and work together to help find solutions. And I'll tell you a better method even, which I will talk to you about in a second, which is partnering also with the community. And then once we have developed these methods, let the clinicians and the healthcare settings implement these. So what's my calling? My calling is to partner with communities, underserved communities, particularly African-American, some in rural areas, some in urban areas, and to find out what their cultural values and healthcare preferences are, as well as what their lived experiences are of racism. And then in partnership with these communities, build programs that are based on their cultural values and their care preferences, not on ours, but on theirs. And then begin, we've built training programs to train clinicians in the cultural values and the preferences of particular underserved community. And one of the ways of changing health disparities, there are multiple ways, as you see: improve medical school training, address provider bias, etc. One of them is to conduct community outreach and provide culturally competent care. And those are the two areas that I focus on. So let me tell you about the social justice. It's not a method, it's really an approach that we use in developing programs. The approach is called community-based participatory research. It is a method that's proven to reduce health disparities. In other words, you want health equity, this is what we need to be doing. This is the direction we need to do. But it's widely used in public health. It's widely used in cancer prevention. It is not used in medicine and not in palliative care until we started doing our work, and a group with Native American populations have started to do their work. It is a method of partnering with communities. Let me give you some examples. It is an equal partnership. It is not one where we're the ones who know it all because we have the degrees and so on and academic knowledge. No, it is an equal partnership. And it's the community that guides the research. Whatever your project is, they guide you before, during, and after, and we listen to them. We listen to what the community says because they live in the community, they know the community, so we follow their guidelines. And we based our programs based on the cultural values of the community. And we start by convening an advisory group of people from the same group that we serve. So this one was African American and white community members in a rural area. They have had experience with the issue we're addressing, which was end-of-life care. So they were either caregivers or widows or widowers or caregivers currently of elders. There were some leaders and well-respected people from the community and the hospital or hospice staff, somebody who understands what it's like to do the care from the healthcare perspective. And these are regular people. It's not like, oh, these are the big donors to the hospital, not at all, completely the opposite. And they participate, as I said before, during and after. And yes, this is again, we listen to them and we implement what they say. And no matter what, even if it's not what we had planned, we change our plans to do what they want. And very time consuming. And of course, it takes genuine respect to build trust and establish trust and to keep the trust going. You know, you're not from our community. Who are you? Why are you here? One of our studies took 4 years to develop. I'll tell you about the study, but what I want to show you here is that the advisory board members, we had meetings every single month. Once a month, we met. I would drive 2 hours to the community every evening and we would meet. And you know what? Only one person, who's the lady sitting in front of that palm tree, she, or whatever that is, looks sort of like a palm. Anyway, so she was a widow and her husband was a widower and they met at church and they got married and the group said, no, that's okay, you can miss that one meeting. Other than that, everybody was there. And we used this method to develop the first ever culturally based palliative care. It's a consult and it's also delivered via telehealth because it's in a rural area. It's for rural, Southern, African American and white, and it's built on the lived experiences and the cultural values and preferences for care of African Americans and white, and that there are various differences, which I'll show you, between the African American and white groups, like how to discuss prognosis, advanced directives, how to connect with the patient and the family. There are even differences there. It took 4 years to develop it, but it's the first ever culturally based palliative care program that was developed by the community, for the community, and it's a model. So other people can take a whole other community and do the same. And if you read just one article, it would be really helpful if you could read table 12 in this article. If you don't have the time or are not interested in the rest, just listen to what the community members said and what they recommend in table 12, how to conduct a consult. I'm just going to give you a few examples. So for example, in the African American community, never call a patient by the first name unless you're invited to do so. The community members also asked for us to take time to get to know the family, like learn something about the family. Oh, so the person is maybe somebody who's a custodian in a school, and that's what you may think of them, that they've had lower education and so on. However, in the church, they may have some big role and they're very well respected because of that role, and which would give you a very different perspective about the patient. And then you repeat it back during the conversation when you're talking with the patient. I mean, it was so important to the African-American patients to be known, to be seen, to be real, as opposed to being judged, which is what their normative experience was like. The other thing was about prognosis. Never be blunt and never say, oh, you are dying, and give a date and time. Always stress hope, and it's in God's hands. I recognize that that's a difficult concept. We do have a training that we're happy for you to participate in. I'll show you the flyer as we go along. It's key to understand the community, no matter how difficult it is for you. And then there are several other things. We don't need to go into it. You can look at it. But basically, what I'm saying is together we created a palliative care program that's appropriate for African Americans, elders and their family, and white elders and their families. We implemented it in the local hospital, and most patients and family were willing to accept it. And those who did were very satisfied with the concept. Here's the thing, the community has ownership. It belongs to the community now. And this is what I was saying is the key about this model. We're now testing its efficacy in a randomized controlled trial in 3 rural hospitals in 3 southern states, Alabama, Mississippi, South Carolina. What you see in orange is the advisory group. Each of these sites has a community advisory group. And what patients are randomized to either the care that they would get in the hospital. These are all older patients, either African-American or white, so the regular care. And some are randomized to receive also the culturally based care that was developed by these community members. And we'll look to see, we're in year 2. Of course, COVID really stopped a lot of our enrollment. It has delayed us by a year, but we are enrolling as we speak. And at the end, we'll be able to say if this is more effective. Imagine if it's more effective, that'll be the new norm. So as I said, this is a model. So other cultures are doing it as well, replicating it. For example, Dr. Agbeko in Ghana, Dr. Vieira in Puerto Rico. Dr. Patel is looking at it, wants to look at it in a Hindu population who are older in North Carolina. We have started another study with LGBT group, who's another very disadvantaged group. And I started a training in people who want to learn about CBPR, which is this partnership method. We did it for the first time this year. For the first time ever, we've had palliative care physicians who are not at all researchers come to learn about it because they want to do something that's more for their patients. They see what's happening is not appropriate, it's not right for their patient population, and they would like to have training. And of course, I can mentor them throughout the process. So it's very exciting that palliative care is now learning about this. Let me tell you about the second study that we used to develop this training, a training for clinicians. And it's a series of videos. Here you see the advisory group watching a video being filmed. It's based on Southern African American communities' lived experiences and their care of preferences. And they've created skits. I'll show you how in a sec. They've created skits with specific messages for clinicians who are caring for older African Americans. A lot of people who have done this training may have not come from the South, but they feel that many of the values that were recommended are appropriate for their community members too. And so just showing the videos isn't sufficient. So our education director, the director of fellowship, he added a training module based on adult learning skills. And I think by now we've had over 100 clinicians who have gone through it. It's a 3-hour module. And there's a very high demand around the country for this training. Here is the training information. If you're interested in it, just email me and I'll send you where you can apply for it. It's called, the community called it African American Communities Speak to Healthcare Professionals. This is caring for African Americans. I have the colleague who has done the training with us. Now she is going to be doing it with some Latinx community in San Antonio. And now we're looking at goals of care because we know that there's a very low goals of care completion among African Americans because we're kind of shoving our method on them. And what we really need to do is ask African Americans what they would like and then build a program based on their values. And this study is going on. So in short, there are 4 steps that you need to develop a culturally based justice-focused program. First, and you can not do this for research, you could do this as a program. You listen to the voices of the community. And then you build programs based on what the community values. And then you train clinicians in this program so that the clinicians have a chance to sort of think through what does the community want. And then we hope that it'll get implemented in healthcare settings. And what we found is that many of the clinicians who were trained in this method are now implementing what the community wanted in their healthcare settings. So as I said, a lot of times people say, well, what am I supposed to do? I'm just a clinician. Not just, but I'm a clinician, not a researcher, I'm not an educator. This is from, it's called the ABCDE. It's a wonderful paper written 2001. That means for 20 years, we haven't really been listening. Basically, it says, you got to go where he lives. Which is exactly key. If we go to where the community lives, if we listen to the community, if we partner with the community, then we'll understand. But if we don't have the time to do it, here are the ABCDE. A is attitudes. What are the patients and family members' attitudes towards diagnosis? And try and understand about what's common to certain ethnic groups. Read, ask your patients. What are their beliefs? Are they religious and spiritual beliefs? And acknowledge that spiritual and religion may be very important in many cultures, and ask what they want you to know about it. What do you want me to know about your religion or spirituality? How can I help you with that? The third is gain some understanding about the cultural context, like their background experiences, or like we talked about systemic racism, and how will these impact how will these experiences impact their care? D is for decision-making. How does the patient make decisions? Is there deferral of autonomy? Would you like your family members there? Would you like your pastor there when you make a decision about what healthcare, what goals, what direction you're going to do? And finally, it's amazing how people forget about this, is what is the resources that are available to the patient and the family? Sometimes, you probably know this better than I, that certain drugs of opioids or so on are recommended, and then you can't get that in that particular environment, in that neighborhood, or there is no transportation, or there is no money, or the reality of what's happening, and then find the agencies that can help provide this care. So this is an ABCDE. It seems very simple. It's obviously much more in depth. That's something that you could do. The Take Our Training course, it's something you could do. If you ever want to do more of this research, certainly we'll be doing this training again, and you can participate in it. The most important thing, I guess I'm asking, is there was a huge movement in healthcare called White Coats for Black Lives, and people were really moved, and people really wanted to make a difference. Let's make sure that we don't just say these things, that we don't just do this at a one time, but continue and feel it and do it every single day. And if you want to find out more about the training that I talked to you about, or about conducting your own research, just email me, very easy. R is the initial, and then Elk, which is the last name, and then UABMC. Feel free to follow me on Twitter, because I write a lot of things about health equity on Twitter, if that's something that you're interested in. And I hope that this talk has given you some sort of idea about what's sort of important about culture, and how it impacts our everyday life in palliative care, end-of-life care, or patients with serious illness. And I hope that you're motivated to do something. Thank you so much. Enjoy the rest of the conference. Take care to all.